this recorded lecture, we'll be going over Chapter 8, Drugs for Allergy and Respiratory Problems in the Introduction to Clinical Pharmacology textbook. When a person comes in contact with a substance or allergen to which they are sensitive, an excessive reaction that leads to an inflammatory response can occur. This is known as an allergy. Allergens are typically harmless substances, and they include things that we're surrounded with every day, including dust mites, plant pollen, pet dander, food, and insect bites. These substances can cause allergic reactions only in people who are overly sensitive to them. Allergies are also known as hypersensitivities, and these can occur when the immune system overacts and develops a response to the substances in the environment. The lymphocytes make 5 different antibodies or immunoglobulins for protection: IgA, IgD, IgE, IgG, and IgM. The IgE class of antibody is our body's defense against all allergens. After antibodies have been released in response to the allergen, they will trigger other immune system cells and mast cells to produce internal chemicals. These are known as mediators. They will start and continue the inflammatory process. The important mediators released by white blood cells when antibodies react with allergens are histamine and leukotriene. Histamine will start the inflammation, and then leukotriene works with the histamine to keep that inflammatory response going after it's been initiated. These mediators, especially histamine, will cause contraction of the smooth muscle and dilation and leakage of capillaries. This explains the symptoms of swelling, redness, tissue irritation, and mucus production. Anything that interrupts the passage of air from the airway to the alveoli can cause death. Disruptions that create problems would include a bronchospasm, pulmonary edema, and collapse of the bronchioles in the alveoli themselves. Drugs that are used to treat allergies include those that interfere with the inflammatory process. These would be antihistamines, leukotriene blockers, and corticosteroids. Leukotriene blockers are used to treat asthma because allergies often trigger asthma attacks. Drugs used for allergies can be taken orally, used as a nasal spray, or inhaled into the lungs when inflammation triggers asthma. An antihistamine is a drug that stops histamines from attaching to the histamine receptors on cells and therefore stops producing inflammatory and allergic symptoms. When the mast cells are activated, they release histamine. There are 2 types of histamine, H1 and H2. Antihistamines do not prevent histamine from being released. Instead, they block the receptors on the tissues. Antihistamine H1 receptor blockers, also known as antagonists, can be used to treat almost any type of allergic reaction. This includes allergic rhinitis. They are also used to treat asthma that is triggered by an allergic reaction. Antihistamines are classified as first-generation drugs or second-generation drugs. First-generation drugs are available over the counter. These drugs are typically effective in helping reduce symptoms of sneezing, itching, runny nose whenever used for a short time. Second-generation antihistamines are newer. They typically have a more rapid onset of the relief of sneezing, itching, and rhinorrhea. In general, they're less effective against nasal congestion than first-generation antihistamines. Drowsiness is an expected side effect for most antihistamines. Patients should also expect dry mouth, increased heart rate, increased blood pressure, dilated pupils, and urinary retention to occur due to the anticholinergic effect of antihistamines. Most adverse effects can be related to the severe anticholinergic symptoms, including cardiac dysrhythmias or a dangerously high blood pressure. A rising intraocular pressure in patients with glaucoma can also worsen the disease and lead to blindness. Symptoms of overdosage include nervousness, anxiety, fear, agitation, restlessness, weakness, irritability, talkativeness, and insomnia. These symptoms can progress to dizziness, lightheadedness, tremor, hyperreflexia, and can further progress to confusion, delirium, hallucinations, and euphoria. On page 118, see the lifespan considerations in the green box. Older adults will typically have a more pronounced anticholinergic effect, often presenting as constipation, dry mouth, and urinary retention. This is especially common in men. The sedative effect often seen with antihistamines will be increased when other CNS depressants are used with the antihistamine. When antihistamines are used along with ototoxic drugs, such as large doses of aspirin or other salicylates or streptomycin, the antihistamine may relieve some of the symptoms of ototoxicity, including dizziness. As a result of this, important symptoms can be masked. They can also interfere with the effects of the anticholinesterase drugs. Assessment. Ask the patient about the presence of a drug allergy, any other drug use, or the presence of asthma, glaucoma, peptic ulcer disease, prostatic hypertrophy, bladder neck obstruction, respiratory or cardiac disease, and the possibility of pregnancy. Antihistamines for an allergy should be taken only when needed. The type and dose should be chosen for the desired effect and the person being treated. Giving oral doses with food or drink can limit GI side effects. However, some antihistamines should be taken on an empty stomach. Long-term use of topical nasal antihistamines will increase the risk of sensitization, often causing a rebound effect, which will increase the symptoms that you are trying to stop. Assess your older adults for side effects, including dizziness, syncope, and confusion. Problems with dyskinesia and bradykinesia, stiffness, and tremor can be reactions that may develop and need to be reported to the provider. Patient and family teaching. Teach your patient and family the following. Unless they restrict their fluid intake due to another health problem, they should be drinking extra fluids to prevent any respiratory tract dryness. If any skin reactions occur, taking the drug immediately and notify the healthcare provider. Avoid tasks including driving or activities that will require alertness until you know how the antihistamines affect you. If the drug causes stomach upset, you should take it with meals or milk. You may develop a tolerance to the antihistamine. If the drug seems to stop working over time, your healthcare provider may suggest trying a different one. While taking an antihistamine, you should not be taking any other drugs without the knowledge of your healthcare provider, especially sedative medications. A leukotriene inhibitor, sometimes called a leukotriene modifier, is a drug that blocks the leukotriene response and lessens or prevents the symptoms of allergy and asthma. Different leukotriene inhibitors have different actions to reduce inflammation. Some leukotriene inhibitors are used for allergic rhinitis. These drugs are also used for prevention and long-term treatment of asthma. Leukotriene inhibitors are generally safe and well tolerated. A headache, nausea, and diarrhea would be the most common side effects. Although adverse reactions to leukotriene inhibitors are rare, liver dysfunction is possible with long-term use. The leukotriene inhibitors will interact with drugs that stimulate liver metabolism, including phenytoin, phenobarbital, carbamazepine, and rifampin. Montelukast has the least number of drug interactions. Assessment. Ask about the possibility of any pregnancy, breastfeeding, or liver disease. Leukotriene inhibitors should not be started if the patient is having an acute asthma attack. Therapeutic effect should typically be seen in 3 to 7 days, with a reduction in the number and severity of allergic reactions or asthma attacks. Patient and family teaching. Tell your patient and family the following. To report any increase in asthma attacks or allergic symptoms. Consider not taking the drugs if you are pregnant or breastfeeding, although this is an individual decision to be made by you and your healthcare provider. These drugs are used to prevent, not stop, an asthma attack or allergic response. Therefore, you should not suddenly stop taking the drug or decrease the dosage. Mast cell stabilizers are another type of drug that reduces the amount of histamine and leukotriene release. These can be helpful for allergies and asthma. They will work on the surface of the mast cells and prevent them from opening to release the inflammatory mediators. A decongestant is a drug that reduces the swelling of the nasal passages. Decongestants reduce allergy symptoms, but they do not reduce inflammation. There are two kinds of decongestants, sympathomimetics and corticosteroids. Sympathomimetics are drugs that produce or mimic stimulation of the sympathetic nervous system, and they have the same action as the body's own adrenaline. After the blood vessels shrink, the secretions in the membranes of the nose can then drain better, and stuffiness and pressure are relieved. Most of these products are available over the counter. A saline nasal spray and saline irrigations using a neti pot are effective alternatives to nasal sprays. These can be used routinely to relieve nasal symptoms without any side effects, and they can be used as often as necessary. A corticosteroid is a drug built on the structure of cholesterol. It is able to prevent or limit inflammation and allergy by slowing or stopping the production of mediators, histamine and leukotriene. Corticosteroid nasal sprays are effective at controlling nasal inflammation. They will work on the white blood cells that help to fight infection. Therefore, their use is not recommended in people with sinus infections or those with immune diseases taking immunosuppressive drugs. It will take up to 2 weeks for corticosteroid nasal sprays to begin to work. Nasal decongestants are used to shrink nasal mucous membranes and relieve nasal congestion caused by allergies or cold symptoms. Local effects include irritation and dryness of the mucous membranes. Sympathomimetic nasal sprays that are overused can enter the bloodstream and cause nervousness, insomnia, tremors, and heart palpitations. Expected side effects of oral decongestants include headache, nervousness, dizziness, insomnia, and tremors. A slight nosebleed is common with corticosteroid nasal sprays, but if it becomes severe, it would be considered an adverse effect. Oral sympathomimetic decongestants can have adverse side effects related to mimicking the sympathetic nervous system response. The adverse effects that can be seen include cardiac dysrhythmias, hypertension, palpitations, all which can lead to a heart attack. Sympathomimetic nasal decongestants can cause rebound congestion if overused, or used for longer than 3 to 5 days. Corticosteroid nasal sprays can reduce the protective immune responses in the nose and the throat. This action will increase the risk of upper respiratory infections as well as the overgrowth of oral fungus. As a result of this, redness, sores, or white patches can appear in the mouth or throat. Drugs that interfere with sympathomimetics would include caffeine, MAOIs, amphetamines, ergotamine, selegiin, and linezolid. These can all cause hypertension and increasing the heart rate with dysrhythmias. Monitor the heart rate and blood pressure in patients taking sympathomimetic drugs, especially in those with a history of heart disease. Oral sympathomimetic drugs can decrease the effectiveness of some other drugs for high blood pressure. They should not be used by patients with uncontrolled hypertension or cardiac insufficiency. Nasal stuffiness and inflammation should be relieved instantly with the use of a sympathomimetic nasal spray and within 1 hour for an oral sympathomimetic. Nasal corticosteroids can take up to 2 weeks to reduce symptoms. Patient and family teaching. Tell your patient and family the following. Before using a decongestant, check with your prescriber. Avoid caffeine, alcohol, and other stimulant drugs. Avoid taking sympathomimetic drugs within 4 hours of bedtime because these drugs can cause insomnia. If you develop extreme restlessness, insomnia, tremors, or heart palpitations, stop taking the drug immediately and notify your healthcare provider. Do not take sympathomimetic drugs if you are pregnant or breastfeeding. Do not overuse the sympathomimetic nasal spray or use it for longer than 3 days. If you have high blood pressure or heart problems, you should check with the pharmacist before using any over-the-counter cold preparations. If you have glaucoma or cataracts, you should check with the healthcare provider before using any corticosteroid nasal sprays. Contact your healthcare provider if any white patches develop in the nose or mouth, if you have worsening nasal discharge, or flu-like symptoms and fever that develop while taking corticosteroid nasal sprays. Although the actual symptoms of asthma can occur from time to time rather than continuously, this disorder is chronic and the person is always at risk for an asthma attack. However, the symptoms of asthma are reversible, and between attacks, the patient will typically have no signs or symptoms. Two different problems can cause the airways to shrink and become obstructed. Internal airway obstruction occurs when inflammation, often caused by allergy, will cause the mucous membrane lining to swell and secrete extra mucus. This is known as bronchoconstriction. Asthma can be triggered by dust mites, cockroaches, smoke, air pollution, pets, weather changes, exercise, and other irritants. Symptoms of an asthma attack include shortness of breath, wheezing, a dry, hacking cough, a feeling of tightness in the chest. Asthma episodes can occur frequently, every day, a few times a week, during the day or during the night, with exercise, or maybe just on a seasonal basis. Management will depend on the severity and the frequency of the symptoms. Chronic obstructive pulmonary disease, or COPD, is a progressive disease that causes breathing difficulty. Bronchitis is included under the umbrella of COPD, and it affects only the airways, not the alveoli. The same things that cause chronic bronchitis will also cause the emphysema that also falls under the umbrella of COPD. COPD causes a chronic cough. It produces clear, white, yellow, or green sticky mucus, wheezing, shortness of breath, chest tightness, and an enlarged chest. In contrast to asthma, the person with COPD will always have symptoms. The lung damage resulting from COPD, unlike that with asthma, is not reversible, although patients can have periods with less severe symptoms. Drug therapy for COPD involves most of the same drugs used for asthma, since the symptoms are so similar, although their causes differ. Drug therapy for asthma and COPD includes bronchodilators and anti-inflammatory agents. Drugs that can help thin secretions, such as mucolytics, are used more often in COPD therapy than they are in asthma. The goals of drug therapy for asthma include preventing acute asthma attacks and stopping an asthma attack as quickly as possible after it begins. Controller drugs, asthma controller drugs, have the main purpose of preventing an asthma attack. These must be taken on a daily basis to be effective, even when the person has no symptoms of asthma. Drugs that have the main purpose of stopping an asthma attack after it has started are asthma reliever drugs. These are typically short-acting bronchodilators, and they have no role in asthma prevention. A bronchodilator is a drug that relaxes the airway smooth muscles, allowing the lumens of the airways to widen. The main action of bronchodilators in asthma and other respiratory diseases when the airways are constricted is to act like the body's own adrenaline. It binds and stimulates to the beta-2 adrenergic receptors with the bronchial tube smooth muscle and allows them both to relax. The most common class of drugs with this action are the beta-2 adrenergic agonists. When a cholinergic antagonist is given, there is less acetylcholine present to interfere with the work of the body's adrenaline. The use of a bronchodilator in asthma and COPD will depend on the drug's duration of action. A short-acting beta-2 adrenergic agonist, or SABA, is an orally inhaled drug that will bind rapidly to beta-2 adrenergic receptors and can start smooth muscle relaxation within seconds to minutes. As a result, SABAs are used during an actual asthma attack when the person with COPD has symptoms of bronchospasm. SABAs are reliever drugs. They act quickly. Their effects will also wear off quickly, so a person may need more than one dose to stop a bronchospasm or asthma attack. SABAs are frequently prescribed to be given with inhaled corticosteroids. The drugs will work together to prevent bronchospasm. When using a SABA and inhaled corticosteroid together, it is always important to use the SABA first in order to open up the airway and then allow the corticosteroid to reach that respiratory tract. On page 124, see the top tip for safety as well as the memory jogger. Teach patients with asthma to always have their SABA reliever drug with them at all times, because an asthma attack could occur anywhere, and only a SABA will work fast enough to prevent a severe attack and ultimately death. When using a SABA and inhaled corticosteroid together, always use the SABA first. It will not work the right way if the SABA is not used first. Some beta-2 adrenergic agonists are long-acting drugs. Although they work in the same way as a SABA, they will take a longer time to build up an effect, and their effects last longer. These are known as long-acting beta-2 adrenergic agonists, or LABAs. They are orally inhaled drugs that bind over time to beta-2 adrenergic receptors, and they are used as an asthma controller drug. LABAs are not helpful during an acute asthma attack because they will not work in time. Cholinergic antagonists are used only as orally inhaled controller drugs. Their response is slower, but they work by relaxing the muscles around the airways so that the airway can open even wider and then breathing is improved. Like LABAs, cholinergic antagonists will not stop an asthma attack or a bronchospasm once it has started. Xanthine-based drugs are older types of bronchodilators that are given systemically. These are used only when other types of management have not been effective. Patients must have their blood levels measured frequently to ensure that the drug level is within a therapeutic range and is not becoming toxic. Orally inhaled bronchodilators usually have a few and only mild side effects because most of the drug goes into the airways. Common side effects do include hypertension, tachycardia, headache, and insomnia. Some people will feel nervous, and they might have tremors with these drugs. Dry mouth and a bad taste are common side effects. Cardiovascular side effects are more noticeable with the SABAs because their onset of action is so rapid. Some inhalers will contain a preservative, and a patient may have an allergic reaction to that. Drug interactions that can occur between bronchodilators and NAUIs, tricyclic antidepressants, beta blockers, and other antihypertensive agents, as well as digoxin, potassium-losing diuretics, and caffeine-containing herbs. The combination of 2 or more of these agents can produce an additive effect. Ask the patient whether or not they're pregnant, breastfeeding, or have a history of hyperthyroidism, heart disease, hypertension, diabetes, glaucoma, seizures, or psychoneurotic disease. It's important to take a baseline set of vital signs to be able to assess for any drug-related changes. One of the drawbacks of bronchodilators is that they may also stimulate receptors in the heart. These are beta-1, that they can then increase the rate and the force of cardiac contraction. Therefore, bronchodilators should be given with extreme caution to patients who already have cardiovascular, endocrine, or convulsive disorders that can be affected by this drug. The route of administration of bronchodilators will vary according to how ill the patient is and the preparation to be used. How well the orally inhaled drug will work to control or relieve the asthma and bronchospasm will depend on the correct use of the inhaler. Show a patient how to use the inhaler for the first time and give them written instructions to refer to later. Each time the patient comes in for a healthcare visit, you should ask them for a return demonstration of how the MDI is being used. Irritation of the lung passages, mouth, and throat can occur with the use of powdered drug forms or other inhaled agents. So rinsing the mouth with water after each treatment will reduce that problem. Check your patient's pulse and blood pressure and then compare them with your baseline findings to assess whether or not the heart is being affected by the drug. Response to therapy will vary among patients. Teach your patient and family the following. Take the drug directed and do not change the dose. Overuse of these drugs will result in severe side effects. Contact your healthcare provider if the drug is not helping you breathe better. Contact your healthcare provider if bronchial irritation, dizziness, chest pain, insomnia, or other changes in symptoms occur. Drink lots of fluid, especially water. Do not take any over-the-counter drugs without checking with your healthcare provider. To prevent exercise-induced bronchospasm, use your reliever bronchodilator inhaler 15 to 30 minutes before starting to exercise. Shake your inhaler well before using it, and follow the instructions for correct use of the inhaler. After using your inhaler, always rinse your mouth with water to decrease any dry mouth and bad taste. Keep account of the total number of sprays used and discard the inhaler after 200 sprays. For an MDI, you must clean the mouthpiece and dry it at least once a week. A corticosteroid inhaler must be used after a SABA inhaler when you are using them both. Anti-inflammatory drugs have a major role as controllers for asthma therapy and the inflammation associated with COPD. A mucolytic, sometimes called an expectorant, is a drug that decreases the thickness of respiratory secretions and aids in their removal. They are thought to work by increasing the amount of fluid in the respiratory tract and may help break down or dissolve mucus, making removal of secretions easier. Guanefacin is a mucolytic drug contained in many combination over-the-counter cough and cold products. Guanefacin can be used to treat symptoms of productive cough. On page 128, see the green lifespan considerations box. The FDA recommends that these products should not be given to children younger than 2 years old, and some products should not be given to children under 6. This is due to cases of overdose. GI upset is a common adverse reaction to mucolytics. Dizziness, headache, and rash can also occur. Ask the patient about a history of cough, the presence of other respiratory disease or allergy, and the use of other drugs that can cause drug interactions. Mucolytics are not to be prescribed for a persistent cough without the advice of a healthcare provider. Chronic or persistent cough may be the result of a serious condition, and it shouldn't be ignored. In addition to drug therapy, you must teach patients to drink more fluid every day and to breathe in humidified air to help thin those secretions. Suggest that they take their mucolytic with a full glass of water. Tell the patient and family the following. The purpose of mucolytics is to make the sputum more liquidy and easier to spit up when you cough. Use a humidifier and drink at least 2 quarts of water daily while taking your mucolytic, unless there is a medical reason for fluid restriction. Notify your healthcare provider if the cough is present with a high fever, rash, or persistent headaches, or if the cough returns after it's been under control. Use the drug only in the dosage recommended to decrease the odds of side effects. Take the drug with at least 1 full glass of water. To cough effectively, you should sit upright and take several deep breaths before you try to cough. Avoid driving or any other activities that require alertness until you know how you will respond to this drug. An antitussive is a drug that can be used to relieve or suppress coughing. These drugs can act centrally on the cough center in the brain, peripherally by anesthetizing stretch receptors in the respiratory tract, or locally, primarily by soothing irritated areas in the throat. Antitussives containing controlled substances will typically require a prescription, although some states may allow codeine combination products to be sold over the counter if the patient is signing for them. The main action of an antitussive will depend on whether an opioid antagonist is included. Narcotic or opioid antitussives will suppress the cough reflex by acting directly on the cough center in the medulla of the brain. Common side effects of antitussives include drowsiness, dry mouth, nausea, and postural hypotension. Pseudoephedrine has been diverted for use as a substrate for the illegal synthesis of amphetamine and methamphetamine, and the sale of purchase of all over-the-counter products containing pseudoephedrine or ephedrine are controlled, and they must be signed for at the pharmacist's counter. Those antitussives that also contain codeine are likely to cause constipation. Opioid antitussives will have an additive effect when combined with other CNS depressants, and their dosage should be reduced. Ask your patient about any allergy to antitussives, the presence of COPD that may influence a patient's response to an opioid, possibility of pregnancy, and the use of any other drugs or alcohol that could cause a drug interaction. Opioid antitussives can cause drug dependence. These preparations can also cause drowsiness. Teach the patient to avoid tasks that will require alertness after taking the drug. Antitussives are oral drugs that should be used only for short periods of time. A short therapy will decrease the risk of rebound symptoms for prolonged use or the possibility of abuse. Teach your patient and family the following. Take the drug as prescribed and do not change the dose or frequency. Use caution when doing tasks that require alertness while taking an opioid antitussive. Overuse of codeine-containing antitussives can cause severe constipation. Do not take opioid antitussives with alcohol or any other drugs that slow the CNS, because it will have an additive effect. Change position slowly when getting up from a lying or sitting position because many antitussives occasionally cause lightheadedness, dizziness, or fainting when you get up quickly.